Welcome to the Learning Lab. My name is Roman Garcia. The video today is going to be dedicated more for professionals, those professional individuals who work with patients who suffer from osteoarthritis, especially of the knees, because that's basically what we've been concentrating on in these last few videos. So many people out there are suffering from knee joint or knee arthritis. Now, the video today is going to be dedicated to those individuals who are interested in learning a whole new paradigm on how to treat or to evaluate or to objectify their patients when they come to their clinics. Now, I found it interesting that for all this time we've been demonstrating our methods of characterizing or objectifying knee joint or knee arthritis condition. But I have never actually demonstrated how those biometrics are created on an X-ray film or on a picture of an X-ray. So what I'm going to do today is I'm going to show you how to create those lines which tell the examiner how to structurally define their knee cases, their knee osteoarthritis cases. Because for the longest time, I've been practicing in the orthopedic domain for many years now, and the impetus for me to develop this biometric characterization or objectifying our knee arthritis was with the frustration that I experienced in the available data or the available examination techniques that existed that gave the examiner the ability to objectify structural changes in their patients. So as the examiner, the interventionist, would be able to follow better the progression of their patients. There's never been any kind of objective technique that I am aware of that gave this power to the examiner. So what I'm going to do today is I'm going to show you how these biometrics are designed onto an X-ray film, so the examiner can follow objectively the progression or the non-progression of their intervention on individuals that come to them with knee arthritis. But before I do that, there's this issue. There's these two schools of thoughts, really only one school of thoughts that are mainly followed by most practitioners, which is an ideology that most follow. And I'm going to show you an example of an example of an individual spouting out that ideology as to how it is that bowing or knocking of the knees develop. Now, what I would tell you is that back in the 90s, there was a very popular seminar or course that many in the orthopedic community went to. And it was called When the Foot Hits the Ground, Everything Changes. And that is the cause of this ideology that's followed by most, if not all, interventionalists who deal with knee arthritis as to what is the cause of knocking and bowing of the knees. I find it a little bit disturbing that this ideology is still followed among many professionals in the orthopedic domain, but I'm going to give you an example. I'm going to let this individual say what I want you to know. Now, this is one example of this ideology being touted as the cause for not knocking or bowing. Now,
the knee joint itself,
observe this video.
It's not really like an entity, it's actually just the result of two.
He's describing how knock knees develop.
I call this a consequential joint because it doesn't really matter what you're talking about in regard to the knee unless you want to talk about what's actually happening in the tibia from the bottom.
You see what he's doing?
From the femur at the top.
He's blaming knocking of the knees or any kind of alignment issues of the knee to asymmetries or to dysfunction in the hip or the ankle joint.
Let's start below, because this is where a lot of stuff happens, and I'm going to show you on myself here how flat
this is classic.
Can really contribute to this knee valgus. And what
this individual is basically saying that knocking of the knee or bowing of the knee, the cause is the ankle itself.
collapses towards the ground as it will, and it over pronates, right, as it will with somebody that
You see,
has
he
flat
blames
feet.
it.
You can
So if
see
you
that
would go to
actually
individuals, you
drives the
would go
tibia
to any
with it.
kind of
As this drives
any kind of
in,
medical
you can see
professional, and
down
you've
here,
got
you
knocking or
got
bowing,
gapping
he's
going
gonna
on here.
focus in on your ankle and your
You got that
foot.
valgus, right?
He's
So you got that
he's gonna
gapping
be
and
under the
knocking
impression, under
because
the
there's
ideology that
overpronation.
knocking
All
of the
your
knee
body
and
weight
bowing of the
driving
knee
down
is
in.
caused by
So
alignment
correct
issues in
this,
the ankle
then we have an
itself.
opportunity
This
to
is the
sort of get
classic.
this
When the
back
foot hits the
out
ground,
and take some of
everything
that
changes
valgus into the
ideology.
knee. If you look at the hip here as well, what we can do is we can get
Alrighty,
some internal rotation.
Carla, that's enough. You can come back to me. This is just a small snippet of basically the ideology that exists out in the public domain. This goes back to the 1980s and maybe even before that. Whether you go to an ortho, physical therapist, chiropractor, their ideology, their thinking, their cause and effect paradigm that they have in their head as to what is causing your knocking and your bowing has to do with what's happening in your ankle. Now, the interesting thing about that, any kind of ideology or any kind of belief system, is that it has to survive many types, many instances where that ideology is challenged. It's similar to gravity. No matter where you go in the world, if you ever get an object and you let it drop to the floor and it doesn't hit the floor and it goes up instead, the ideology of gravity, the principles of gravity are defeated at that moment. For a fact, for a belief, for an ideology to be considered a fact, there can never be one case where, an instant, where the principles that make that ideology, belief, true, cannot be violated. And I'm going to show you right now today one of those cases where it's violated. And if you have one case where what's supposed to happen does not happen, then it's not a fact. It's nothing more than just something that you believe wholeheartedly. They are not following the facts. So what I'm going to show you today is just one circumstances where what's supposed to happen does not happen, and I'm going to use my assistant Anna as the example, because we got the perfect opportunity here. But before I do that, I want to show you how it is that you create these objective markers or biometrics on an X-ray film. This will guide you in your interventions, because basically these metrics describe the structural characteristics of a joint. And by following these metrics, it will guide you toward understanding the cause and effect of bowing or knocking. And it will allow the practitioner to modify his treatment so he can start thinking in terms of, how do I create structural changes, not in the ankle, not in the hip, but where it counts, which is in the area, is in the region where you're going to get where the knocking and the bowing are occurring independently of the ankle or the hip. Now, this is one case that we had recently. We treated her. This is before treatment. This is actually the same patient. This is the right knee. This is the left knee. This is the right. This is the left. Now, you can see that the left had a joint replacement. We were treating her native tissue, which was the right. And this is a picture of the right. Now, this is how you draw your vector lines and your magnitude triangles. This is what you do. This is an X-ray picture right over here. This is the medial tibial eminence right here, and then this is the lateral. These are just two little spikes that come off the center of your lower bone, the tibia. This is pretty much where your ligaments attached. So what you do is that you try to be consistent with your starting points, and your starting points where the lines take off. That's all you have to do. So I just decided arbitrarily to start the vector line, which tells you whether the knee is bowing or knocking. And I always use the medial tibial eminence right over here. So you get a ruler if you don't have an electronic X-ray machine, which is what I use, but you can easily be done with a simple ruler and a marker on X-ray film. This is obviously not X-ray film, but these are the X-rays. So what do? You find the tibial eminent line and you use the most lateral part, most lateral region of it. In this case, in this patient, those protuberance are clearly seen. They can easily. In some cases, you can't see them because there's so much degeneration, but you can always approximate where it is. In this situation, it's very easy. So my starting point is the lateral. This is the tibial eminence right here. You start at the lateral point. This is the medial point. This is the inside, this is the outside. At the lateral, you try to create a vertical line as much as possible. Yes, as best as humanly possible as you can. Yeah, and you draw a line straight down. Straight down. It's not going to come out perfect, but it's a good approximation. And that's the point, a good approximation. Now, the next thing you do is, you come to the lateral portion of the tibia, right over here. You try to bisect the joint space width. Again, the important thing is to be consistent. Right here, the middle, and you draw a line straight across. Again, from the lateral, most lateral portion, and now you come and you do the same thing to the medial side, the medial joint space width. You dissect the center. And you start off at the most lateral point, the center, and you try to stay as straight as possible. And now you create a right triangle. More, it's like pyramid, but a right triangle. These are your magnitude loads. This tells you where this individual weight-bearing loads are falling, on the inside or on the outside. Okay, and you do the same thing with the medial. Again, you want to create a right triangle. Okay, and there you go. That's pretty much how it is. All right, so this was the initial evaluation. Now, when you look at it, this vertical line right over here, this is your vector line, your stress vector line. Remember, you've seen these videos before. We know that when this line crosses the inside, the knee is in knocking. So you cannot appreciate it unless you create some objective Euclidean geometry onto the board. This is as objective as you can get. Now the vertical straight line tells us that this knee is in a knocking alignment condition. Now, if you look at the magnitude load, the triangles are what you would expect. There's more weight-bearing load because she's in knocking on the outside. So the line, so she has more weight-bearing load on the outside, and she has less weight-bearing load on the inside. This is what you would expect in a classic knock-knee pattern. Now, this is your starting point right over here. This is what we started with our patient. We introduced our intervention. That's what we did. And we gave her all that she needed to know. She went home, she implemented everything. We intervened in the clinic with some biologics. In this case, we used a smart brace on her too, because she was in knocking. So we introduced a smart brace to unload, to decrease the magnitude of this triangle right over here, because that's what we needed to do. So that was pretty much it. We gave her instructions on what exercises to do, what not to do. Really, exercise-wise, is really what not to do. It's not what exercise to do. A lot of the ideology out there with what causes bowing and knocking is that the individual has weakened muscles. That's the most ridiculous concept I've ever heard in my life. Because these individuals go into knocking or bowing based on stress acquired throughout their whole lives, and it changes the structure of the joint, which is basically what these these geometric figures right over here is giving the examiner, is giving you an objective observation of how the structure is and how the weight-bearing loads are falling on this knee and how it is manipulating the structure itself, is changing it, it's adapting to these abnormal weight loads. Now, after a few months, she came back for a follow-up, and this is the view right here. This is the follow-up examination. Now, what you can see without doing the geometric lines here is that the joint space width on this inside over here is definitely more pronounced. You can actually see a better defined medial compartment. The lateral compartment is also better defined. Now, what we do now is that just from observing, it looks better. But what we're going to do now is we're going to create these vector lines on this post X-ray examination and see if there's any difference. So we do the same thing. We come over here. We find the tibial eminence, straight line. A straight line again. Okay, straight line. It's not perfect, but it's right here. Gives you a good approximation. Again, when we do this in our clinic, we use computer algorithm to help us with this. So the lines are always exact. But the important thing is that you understand how to do them. And if you have to do it with a ruler, it can't be done because that's how we started. This is how we started this process ourselves, this protocol. Again, to the tip, to the outside. And again, now we draw the lines again. Again, now these are the magnitude loads. Again, it's basically what we want to do is again, magnitude loads. These pyramids right over here, this gives you the quantity of the weight-bearing load, of how each compartment is contributing to the weight of the body. Now, this is the interesting thing. Look at the vector line. Look at this one. This is pre, this is post. You can see that she went from knock knee, painful knee, to a vector line, which is more towards a neutral to a varus. Now let's look at the triangles. Look how the triangles have changed. Again, this is the same X-ray machine, same X-ray technologist, and he doesn't know that we're collecting the data. So he's completely oblivious to the facts. So he just goes and he does what he does the same over and over again. So he uses the same technique, same angulations. You can see that there is really no difference in the perspective of the X-ray beam. These two were taken under identical conditions. The only difference was between this one and this one was the intervention and the time and the tissue's ability to adapt to the intervention itself. And therein is where my point is of all this. The new paradigm is the belief by the orthopedic community, by the medical community in general, that believes that tissues do not change. That structure is something that once a tissue is in a degenerative state and the structure is what it is at that moment, it cannot reverse itself to a normal state. It doesn't reconstitute itself. It doesn't regenerate itself. And therein is where I say that that is a false idea. That is a very old paradigm and doesn't take into consideration the body's ability and the evolutionary process and the millions of years that it took for the body to adapt itself to its environment. And it can only do that if the body maintains its ability to adapt to the environment. And that's basically what we did with this patient. We changed her environment. And this is the proof that the structural changes occurred, because these vector lines do not lie. You can see that they do not lie, and they're very different from beginning to end. The medial triangle, magnitude triangle, it's bigger than it was initially. Even the lateral is more symmetrical, even though she's still she's still converging more stress on the lateral compartment, yet it's more symmetrical to what is normal for her. Why did this happen? Because the tissues and the structure changes. It changes if you change the environment where the tissues are being exposed to weight-bearing loads itself. The tissues adapt, they change, but you gotta be able to follow that progression. And this is really the only way that it can be done. There may be other systems out there, but this is the one that we use, and this is the one that gives us the most data. And this is something that anybody can do in their offices. And now what I wanna do now is, I'm gonna disprove this idea that knocking and bowing is caused by changes in the foot or issues in the hip. I'm going to disprove that. It's a simplistic and quite stupid idea, to be honest with you, to believe that and to express that idea to a patient. So what I'm going to do is, I'm going to show you that one instant where this ideology is destroyed completely. And I'm going to do it with the help of my assistant, Anna. She just wants to say hello.
Hello, everybody. How are you doing today?
Anna, now, this is what I did. Anybody that's been following our videos knows that Anna she knocks. She's knock knee. We've done these measurements on her X-rays before. So what I did is I just drew it on her, so you can appreciate how it would look on her X-ray. Now, Anna's X-ray will look something like this. Since we know that she knocked knees, we know that this vertical line right here is going to fall in the center. It's going to fall on the inside relative to the outside because she's knocking. Her knee goes like this. So this line right here is going to fall inside, just like you saw in that picture pre. That vertical line is going to fall on the inside of her tibia, towards the inside of her tibia, not so much towards the outside. We know that. We know that because she knocked knees, that her magnitude line, her magnitude triangle, her magnitude triangle will be larger than her medial triangle because she knocked knees. If she would be bowing, then her medial magnitude triangle would be much larger than her lateral. So this is basically how her X-ray would look at the initial examination because she's a knock near. Now, Ana, te vas a parar. Now, when she stands, this is how it's going to be. Her vertical vector line right over here is going to fall inside of her tibia. Her tibia is right here. And this is how it would look. Or her weight-bearing load would be out here. This is a classic knock knee. Her medial triangle will be less. Now, because of that, she has the propensity to develop degenerative changes here. Now, this is where the disproof of this ideology about ankle comes in. Acuéstate aquí otra vez. Now, Ana, relax. Now, I've said this many times before. A lot of women, more women than men, suffer from knock knee. It's not always, but it's more than 51% of women will suffer from knock knee than it would be bowing. There's always cases where a woman would be bowing and not knocking. Part of that reason is, it's not the ankle, it's not the hip, is that women have just greater flexibility, they're more lax in their joint. Their ligaments are different for one reason only, and that is because of childbearing. Women need to be more flexible, and that provides an advantage to childbearing. I mean, that's basically what it comes down to. Now, according to the ideology that knocking is caused by flattening of the feet, basically flat foot, this is the interesting thing. Ana knocked knees. You can see that her hips are not excessively wide. as you would expect in most women. There are women with narrow hips, just as narrow as men. So that the knocking is not a function of the hip. It's not because women have large hips and that they knock. It's not it. Anna has narrow hips, yet she knocks. Now, look at her feet. She's not flat-footed. She has a normal arch. In my years of working with patients who have issues with knees, knocking, bowing, it doesn't matter. Most of them have normal arches. Anna has normal arches. Her knock knee is not a product of her lack of arch. Anna is similar to the fact if you drop something to the floor, if it doesn't hit the ground and it goes up into the sky, it defaults the law of gravity completely. The only reason gravity is a law is because as of yet nobody has ever dropped anything and it's gone up to the sky versus down to the ground. That's why gravity and the law of gravity and the fact of gravity holds, because nobody has disproven it through an act where you drop something and it goes up. Similar to Anna. Anna is similar to somebody dropping a pen and not going down into the ground, but going up into the sky. Anna has all the particulars that disproves this old ideology that knocking and bowing is a product of arch issues or hip issues. So there you go. Anna just basically is the pen. Anna is the pen that doesn't hit the ground but goes up into the sky. So if you are interested in learning how to objectify, how to understand a paradigm that will eventually come to the mainstream, it's just a matter of time, contact us. I'll show you this protocol. If you are of a regular foe and you really want to understand what's going on with your knee, give us a call. Contact us. We'll help you understand, or we'll help you improve your clinical examination skill set. Again, for anybody who's seen this video and has seen all our videos and is participating with our educational endeavors, I want to thank you, and until next time, see you soon.